Hi again, this is the recording for high-risk newborn. So in the previous weeks, we have talked about things that we talked about, like high-risk pregnancy, we talked about high-risk labor and birth and kind of the things we look at for that. And so now we're kind of looking at how that from the baby's perspective and how those conditions have affected the baby now that the baby's born. And so some of those things we're thinking about have to do with birth trauma and preterm, postterm, diabetes, stuff like that. So for birth trauma, we know that oftentimes this can be related to a baby that's macrosomic or large. So this can be a time when we could avoid a birth trauma if we know our baby is macrosomic by doing a C-section. And so we talked about that before, that women who are diabetic with poor control, poor glycemic control, and their babies are growing macrosomic, they might be at risk of needing a cesarean. And that's to minimize the effect of, or the possibility of a birth trauma for the baby. And so the main birth injuries that we see are going to be related to things like shoulder dystocia, which is why macrosomia can contribute to that. That's not always the reason that babies have shoulder dystocias, but that's definitely one big one. Other things that we can see that we might not be able to foresee is like the labor dystocia or an abnormal presentation, things like that, that if we could foresee it, maybe we would have planned to deliver with the cesarean, but since now this is where we're at, we could lead to birth trauma. So skeletal injuries, when we think about skeletal injuries, our more common ones are going to be the clavicle. This is the most fractured bone during birth. And this is going to be a hugely going to be a shoulder dystocia issue. Okay. So you remember with the shoulder dystocia, suprapubic pressure is one of the things we do to try to knock that shoulder underneath the pubic bone, and that can fracture a clavicle or humerus. Okay. Humerus and a femur could be fractured during the birth for different reasons. And then skull fractures are the other bone fractures that we see. This can be due to a difficult birth. This could be due to forceps delivery that we see skull fractures. Fortunately, babies' bones heal really well. And so there's not often a lot of intervention that's needed for this. What we might see with a fracture, clavicle, or humerus would be when we elicit the moral reflex of the baby and we get them to startle. Instead of having a symmetric response with both arms, you might see an asymmetric response where the affected side doesn't respond as well. Peripheral nervous system injuries. So what we're thinking about with this is we're thinking about our biggest one is brachial plexus injury. All right. So this is when, again, typically with a shoulder dystocia, we've stretched these nerves through here, or they've been torn completely, hopefully not. And this causes, it causes a paralysis of the affected arm. All right. So if this is pulled or torn, then the affected arm is not moving at all. So now if I elicit a moral response, a moral reflex response, I get one arm and I get nothing on this side. Okay. The things that with this is it takes a really long time for nerve injuries to heal. And so teaching parents how to hold the arm and keep it so that the shoulder stays in its socket and things like that until that heals. It takes a long time. The facial palsy and the Klumpke and the phrenic nerve, these ones are a lot more rare. The facial palsy, it will look pretty significant for a short period of time where half of the face is not really moving at all and the other half is, but it usually resolves within a couple days. So the other thing we're thinking about for neurologic, we're going to be thinking about the fact that if our baby is a low birth weight, they're going to be at a higher prevalence of having things like intracranial hemorrhage. If our baby's very preterm, higher prevalence of intracranial hemorrhage. And this would be because the capillaries are more fragile. Okay, so our teeny tiny babies have a much higher risk of having ischemia in the brain. And that is why we talked about for using magnesium sulfate for preterm labor patients for neural protection. This is what we're thinking about for that. All right. So risks to babies' brains, cerebral palsy is the most common. And that's also often with your preterm birth, and also why we use magnesium sulfate for neural protection. We're not really going to know for a couple of years if these babies, as they're growing into toddlers and they're not meeting their milestones, that's kind of when we have a clue. If you think about all the things that we've learned about with fetal monitoring, all of that stuff we talked about, it was all about keeping our babies oxygenated and minimizing the risk of cerebral palsy. Okay, so even though cerebral palsy is a common one with preterm birth, it's also going to be our big one that happens if our baby is hypoxic. And so that brings us to therapeutic hypothermia. If your baby's over 35 weeks and your baby has been very hypoxic in labor, we have a lot of late decelerations, absent variability, things like that. And they do the cord blood gases and they find that the baby's very acidotic. They're worried that if the baby could develop hypoxic ischemic encephalopathy. And so they can do what's called therapeutic head cooling, where they cool the baby down to give the baby's body time to heal that without to minimize the lasting effects. All right. The other thing we're thinking about with our babies that is a concern is sepsis. So the easiest way to prevent nosocomial infections is to do good hand hygiene. And that's especially important like in our NICUs, because a lot of NICUs are set up with baby bed, and alarms are going off, and it's easy to go from this one to this one and not do good hand hygiene. So we have to make sure we're doing good hand hygiene. For our babies, they have a higher risk of developing sepsis if there's risk factors for mom. So if she has STIs, if she has infection during labor, like chorioamnionitis, if she was GBS positive and we didn't treat her, we have talked about before with group beta strep that if moms are not treated with antibiotics during labor, those babies can contract group beta strep, and it has up to 50% mortality rate for babies if they get it. Okay, so these are all things that are considerations for sepsis. Signs of sepsis is really non-specific. So if I have a baby that I'm concerned about, we might test for sepsis. And so the things that make me concerned are going to be things that oftentimes I might associate with respiratory distress. Tachypnea is one of the big symptoms. I might also think hypoglycemia if the baby's cold, because guys, when babies are septic, they don't run a fever. Instead, they become hypothermic. They have temperature instability. Now remember, temperature instability and hypoglycemia go together. So if I see temperature instability or hypothermia, maybe I think my baby's blood sugar's low. Maybe my baby hasn't been feeding well, because it's also a sign of sepsis, but that might also be why I think the baby could be hypoglycemic. So there's all sorts of things that can play into this. And so if I have a baby that's tachypnic and has temperature instability and they're not feeding well, we should test them and see if they are infected. So the way that they test is they're going to do blood cultures, and we should have, that might have been the previous slide, but yeah, they'll do blood cultures. But what we need to do is we need to make sure we get our blood cultures, and then they might start treating just in case. It takes a while to grow blood cultures out. And if we just sit around and wait and our baby's infected, then we could be risking septic shock. All right, so it's kind of a hard line to walk with that. Breastfeeding is going to be encouraged for babies, especially if they're low birth weight or preterm, for immunity factors. And then also if we suspect septicemia, then breastfeeding is encouraged for the same reason. Torch infections. So these are infections that mom can contract during pregnancy that can have a profound effect on the baby. And so we're thinking about, so this is an acronym. So the T is for toxoplasmosis. Toxoplasmosis is often found in cat feces. So you should, if you're pregnant, you shouldn't clean the kitty litter box. All right. But you also should wash your fruits and vegetables, and you should be mindful of washing your hands if you're, gardening and things like that. The O is for other, and this is like all sorts of other things that aren't included in the rest of the acronym. So this is hepatitis B, HIV, things like that. Worth noting with HIV, that's kind of a big one, right? If mom is infected with HIV, then that can pass to baby. So that's something we talked about wanting to know clear at the beginning of pregnancy so that she can have the antiretroviral, which is Zuvudine. And she would take it through the whole pregnancy, and then they give it to her in labor, and then they give it to the baby in the first 6 weeks after birth, and it significantly reduces the risk of HIV transmission. Okay. Also remember that HIV then passes through breast milk. So we're also encouraging those moms not to breastfeed. I have heard of cases where, because we have come so far in our HIV treatments, that we can get their viral loads down to 0. And I have heard of cases when the viral load is down to 0 that they have allowed for breastfeeding, but those are going to be your rare cases. So for the most part, we're not anticipating moms that are HIV positive are going to breastfeed. Rubella, that's the R. Rubella is an infection that typically we're vaccinated for, but that's one of the things we found out with mom at the beginning of pregnancy with her prenatal visit is she immune or non-immune to rubella? If she contracts rubella in pregnancy, that can have a detrimental effect on the way she grows her baby. It can cause hearing loss for the baby, things like that. But the vaccine is a live virus. So if her rubella status is non-immune, we will not vaccinate her until after the baby's born. Okay. Cytomegalovirus, CMV, this is another one that mom can have and not know. And if the way that it affects the pregnancy, oftentimes those babies also can be born with hearing loss. Actually, where I work currently, if our baby fails 2 hearing screens, the baby gets swabbed for CMV. And then H is herpes simplex. Herpes is something that, if there's a few considerations for this, herpes is so dangerous for babies. Okay, so if mom has a cold sore, she should not be kissing the baby. If she has herpes, then she cannot have, if she has any herpes lesions in her perineal area, she needs to have a cesarean and not deliver vaginally to minimize the risk of spread. And if a baby has herpes, then they have to be on isolation because it's so dangerous for other babies. Okay. So that is the basics of TORCH. Moving on to drug exposed infants. So this is going to be moms with substance use disorder, SUD, and how this affects the baby. So all of these drugs they're taking in their pregnancy cross the placenta. The baby gets it. The baby becomes addicted to it. And so it also will cross the breast milk as well. And so we're thinking about our big things like heroin and cocaine and amphetamines and PCP, but also marijuana crosses the placenta. It also crosses the breast milk. And so it depends on your facility and your state on what the recommendations are with marijuana. Okay. That's not something they're taking methadone for, but it's definitely something that they might be discouraged from breastfeeding for, and things like that. So if your mom is using illicit substances like these, then she could be placed in a program where she could be on methadone or Suboxone, and this is going to help wean her off of the opioids. Okay, she can still use methadone or Suboxone during her pregnancy safely and also breastfeed safely. Okay, and how babies withdraw is going to really depend on how exposed they were. So this is neonatal absence syndrome, or NAS. Okay, so this is our baby's withdrawal, newborn withdrawal, and it's there's so many symptoms that go with this, and these babies are just so sad. Oftentimes we have a really high-pitched cry, irritability, hypertonicity, seizures, tremors, fragmented sleep. They're not doing well. They're not resting. They have a hard time coordinating their suck, so their feedings aren't going well. Oftentimes these babies are doing a lot of sneezing, a lot of yawning. They can be tachypnic and diaphoretic. They can also have temperature instability. And the way that we manage this typically is by decreasing stimuli and keeping them swaddled snugly and holding them. Okay, there's a whole tool called Eat, Sleep, Console, and hospitals are moving towards using this tool. And Eat, Sleep, Console looks at how's the baby eating, how's the baby sleeping, and how consolable is the baby, and then determining if they need medication. So it's got a lot of non-pharmacologic base to it. Some babies need morphine, they need phenobarbital if they're having seizures, things like that. But we're going to try to minimize that. And that's something you can also teach to the parents on how to help with Eat, Sleep, Console. Okay, and so a lot of holding, swaddling. Some hospitals that have a high drug use community will even hire people that just hold babies that are withdrawing from drugs. So different things ways babies can be affected from drugs. A lot of them have learning disabilities and things like that long term. Smoking causes low birth weight because remember we have that chronic vasoconstriction, and babies can withdraw from nicotine too. For alcohol, oftentimes babies that have been exposed to alcohol develop fetal alcohol syndrome. So this is our leading cause of cognitive impairments, and it has distinct features for your fetal alcohol syndrome babies. And then hemolytic disorders. Hopefully you guys are familiar with this by now. This is actually a duplicate slide from another week. All right, we're thinking about blood incompatibility. So RH incompatibility, or ABO. With RH, mom's RH is negative, baby's RH is positive, and we give RhoGAM. And RhoGAM is going to minimize the mom's body making antibodies that would affect a future pregnancy. But let's say she didn't get that, and she got pregnant again with an RH positive baby. That's where this comes in, erythroblastosis fetalis. So if she didn't get RhoGAM and the new baby, this pregnancy again is RH positive, the body now has made all these antibodies and they attack the red blood cells. And so we see it's a hemolytic disease. And so the red blood cells are just being obliterated. Sometimes they can do transfusions in utero, where they can go in with the percutaneous blood sampling, and they can do transfusions before the baby's born. And then these babies are going to be super high bilirubin or hyperbilirubinemic because of all the breakdown of those red blood cells. Okay. And so that is your blood incompatibility with RH. And then with ABO, we talked about how if mom's blood type is O and baby is anything other than O, mom's naturally occurring antibodies can cause hemolysis for those babies. That is not as significant as erythroblastosis fetalis, but it also can contribute to jaundice and anemia for those babies. And so we can do the Coombs testing on either one to look for those antibodies. All right. Infants that are born to diabetic moms. So it was really important for your diabetic mom to have good glycemic control. And we have talked a lot about how we do that and how we teach moms about nutrition and exercise and all the things that they need to do with checking their glucose levels and maintaining a nice steady glucose. If that didn't happen, then these babies are going to grow macrosomic. They're going to be large for gestational age after they're born, and they're going to have a higher prevalence of birth injuries like shoulder dystocia. Okay. Big concern for these babies is hypoglycemia. Their own body makes insulin clear up from like 14 weeks gestation. So their pancreas is pumping up insulin, and so they're getting all this glucose from mom. Now we suddenly cut off that glucose supply, but their body's still making all of this insulin. And so now you can have babies that become severely hypoglycemic. So we're watching their blood sugars closely. We're getting them eating, getting that baby on the breast every 1 to 2 hours and keeping them fed and trying to maintain the glucose. Okay. If we aren't able to maintain the glucose with frequent feedings, then they might need like a glucose gel and things like that to keep their glucose levels up. So we're monitoring that very closely. These babies are also at risk for respiratory distress syndrome. And so think about what we have talked about previously about this. All right. If the baby's body is making a ton of insulin, it actually affects their surfactant production. And so you have these huge chunky babies that are having the same kinds of signs of respiratory distress syndrome as your preterm babies that are teeny tiny, and it's related to that surfactant. Lack of surfactant can happen with these babies. Okay. So we're going to assess for anomalies, okay, because babies that are born to diabetic moms have a higher prevalence of anomalies. We're watching for birth injuries so we can like elicit that moral reflex, see if that our affected site is moving, things like that. We can palpate and see if we feel a fracture. We're keeping the glucose level up. So that's going to be a little bit dependent on facility. In the first 24 hours, we're usually trying to keep it above 40. Truly, where I work currently, we just are trying to keep it above 25 in the first 24 hours, but and then above 50 in the after 24 hours. So it's a little bit facility dependent, but I believe the book says greater than 40. And we're managing signs of hypoglycemia, feed the baby, watch for temperature and stability, because remember, those two things go together. And so keeping baby warm, skin to skin. So moving on to congenital anomalies. So congenital anomalies, it's going to depend. There's so many. And so we're going to talk about a few, but it's not even going to cover, there's so many that it could be. All right. Down syndrome is one thing that we're going to talk about. Spina bifida and anencephaly. Common congenital anomalies that cause serious problems are going to be things like heart conditions. Some of our congenital heart disease things are seen with Down syndrome, for example. If they have abdominal wall defects, neural tube defects, those can all be dangerous. Cleft lip and palate, we're going to look at what that looks like. Hip dysplasia, clubfoot, how we treat is going to depend on the severity of the condition. So sometimes it's a surgical, sometimes it's rehab, sometimes it's just education, it just depends. So let's look at Down syndrome first. Down syndrome is something we talked about. Remember when we were doing our alpha fetoprotein, we were checking alpha fetoprotein and we said if it was low, that means Down syndrome. This is also something that they can test for when they do an amniocentesis and things like that. Okay, so now here's your baby with Down syndrome. They have very distinct features. So they have like close set eyes. They usually have like a protruding tongue. Simian crease is when you look in the hand and instead of having two lines, there's one continuous one that goes all the way across. Their hands are usually short and thick. They have a space between the first and second toes, little fingers curved in, just all these little things. Okay. Your Down syndrome babies can have anything from mild to severe mental retardation. So they're limited intellectually. They can have congenital heart deformities, which we just said. And they're more prone to infection, like respiratory infections and ear infections. Okay. They're also probably some of the nicest people you'll ever meet. Spina bifida. So this is your neural tube defect. So remember again, alpha fetoprotein is low with Down syndrome and elevated with neural tube defects. This is your neural tube defect. So there's a few things. One of them is anencephaly, where the baby actually is missing part of the brain, and that's the more significant. You can also have this myelomeningocele, and so you get an outpouching. All right, so this is spina bifida. If you have a baby that's born with this, then you need to put moist sterile dressing on, keep them on their bellies to prevent pressure on the sac. And you can keep them skin to skin with mom, parent bonding. And this is going to have to be, if they have an open defect, it has to be surgically repaired. Sometimes if you're doing your head to toe assessment on a baby, if you see a sacral dimple, so just a dimple right above the sacrum here, that can also be a sign of a closed neural tube defect. So this is an open one. Hip dysplasia and clubfoot. With hip dysplasia, it just depends on what degree of dislocation we have as to for sure what we're going to see with this. So typically we can see unequal or asymmetric gluteal folds, which is kind of what the picture is showing, is a sign. Also, if you bend their legs. So the Barlow and Ortonelli test was when they would bend the legs and then roll the hips out. Some are still doing that, but we're getting away from that because it actually dislocates the hips to do that. But we can also just flex and see if the knees are even. So if we see anything that's uneven either way, whether it's the gluteal folds or when the knees are bent, it can be an indication of a hip dysplasia. Clubfoot is common if the foot twists inward. It depends on the severity, how they treat it. It might be surgical, it might be splints or casts. And then this is cleft lip and palate. So the top one is your cleft lip, and depending on the severity is going to depend on how that affects the way your baby eats and how they latch. And sometimes they need special syringes or bottles. This over here is a cleft palate. So you can see the hole is actually in the palate. So this baby has a hard time latching, and this is how we found this one. This one was one I took care of. It wasn't known. Oftentimes we know about cleft lip and palate if they had good prenatal care, it's been identified. But this was one that was unknown, and it was because the baby couldn't form a sock when we were trying to breastfeed that we explored this further. Typically these are surgically repaired by 3 months of age, and until then they might need special equipment to get nutrients. And also because of where the holes and spaces are, they have a higher incidence of ear infections. So we teach parents to report signs of ear infection. Preterm babies are born before 37 weeks. These are usually what's in the NICU is our preterm births. All right. The severity of organ issues is going to be dependent on how young the baby is. So the more preterm, the higher prevalence of having difficulties with different organ systems. All right. So respiratory, right? We don't anticipate babies to have enough surfactant until they're at least 35 weeks. So babies before then might have signs of respiratory distress and different things like that. They have a higher risk of infection. So especially if mom was GBS unknown and didn't get antibiotics in pregnancy, then we're being mindful of that. That's oftentimes why we give moms antibiotics if she's in preterm labor. They have a greater surface area to body weight ratio. Basically what that means is they're going to get cold easier. All right. They have a higher incidence of hypoglycemia, higher incidence of hyperbilirubinemia, and they oftentimes need respiratory support and feeding support. Late preterm babies are 34 weeks to 36 and 6. These babies do better. They have still hypoglycemia, hyperbilirubinemia, higher prevalence of sepsis, but typically these babies do better. So they might be in the NICU, but not for as long. And we give them some respiratory support, and then we call them feeder growers, where they're just working on suck, breathe, swallow. That's hard to coordinate, things like that. So complications for preterm birth, respiratory distress syndrome is a big problem. So our signs and symptoms of this is going to be the same or similar to respiratory distress that we learned about in our newborns in general. But the syndrome is related to the lack of surfactant. Okay, so we see respiratory distress syndrome in preterm babies and also in babies that are born to diabetic moms because they're lacking in surfactant. Okay. This is responsible for more deaths than any other disease. So all of those signs and symptoms that we talked about for respiratory distress in our newborns, tachypnea, retractions, grunting, nasal flaring, cyanosis, these are all things we're looking for. And oftentimes preterm babies are getting either oxygen therapy with they can put them under a hood. Most often they have CPAP, and that's what this picture is on the slide. A baby's CPAP goes in their nose, and CPAP is continuous positive airway pressure, so it's keeping those alveoli open. Sometimes babies need an endotracheal tube, and they need a ventilator to breathe. Okay. And if they have an endotracheal tube, they can also be given surfactant through the ET tube. So, for those who have listened to me talk about the placenta previa that was 30 weeks gestation, her baby needed surfactant through the ET tube, and that greatly improved the baby's respiratory status. Okay, complications though, they can develop a pneumothorax or bronchopulmonary dysplasia. So babies that are on mechanical ventilations or using long-term oxygen can develop bronchopulmonary dysplasia. Other things we'll see, meconium aspiration syndrome. So we have talked about that before and how it causes pneumonia. So our signs of that are going to be signs of respiratory distress. Right? Apnea of prematurity, babies that are really preterm often just don't remember to breathe. And so they need medications to help stimulate their neurological system to breathe more. And then complications are going to be sepsis, which we talked about already. So temperature instability, poor feeding, respiratory distress. They have a higher prevalence of hyperbilirubinemia and jaundice, higher prevalence of hypoglycemia. So those babies have a higher risk also of cold stress. So hypoglycemia symptoms, tremors, so the twitchy jitteriness, temperature instability. And then with cold stress, this happens when if the baby's cold, because we also said our preterm babies have a higher risk of getting cold because of the decreased surface area. Or increased surface area, decreased body weight. So they have less brown fat. Babies are born with a layer of brown fat that helps with thermogenesis, and they have less of that. So they can lose a lot of heat quickly, and they can't shiver. So with that, our signs are going to be tachypnea, lethargy, bradycardia. Retinopathy of prematurity, babies that are really early can have retinopathy of prematurity, which can cause blindness. All right, so we're minimizing the amount of oxygen that we're giving babies, and we're maintaining their oxygen saturation between 92 and 95%. They don't have to be 100%. All right. And then necrotizing enterocolitis. So necrotizing enterocolitis is something that can happen, especially with our preterm babies. And it starts with an inflammatory disease of the GI mucosa that can actually perforate the bowel. The best way to lower the risk of this is with breastfeeding. So this is one of the reasons that breastfeeding is strongly recommended for preterm babies. Okay. Signs of necrotizing enterocolitis, one of them is going to be bloody stool. If they have bloody stool, then that's the first thing we're worried about. Post-term babies. Post-term babies are after how many weeks? 42. Okay. And so lots of different things we can see with our post-term babies. We might have seen placental dysfunction. So maybe late decelerations in labor because that placenta is getting old. Um, we can see birth injuries because the baby's bigger, right? Higher prevalence of meconium aspiration syndrome. Less vernix on their skin, more cracking and peeling of their skin, higher prevalence of hypoglycemia. And these babies have an increase of morbidity and mortality and fetal distress during labor. How are we taking care of our high-risk newborns? A lot of it is respiratory support. So again, here's your CPAP baby, and he's getting kangaroo care. So he's skin to skin with probably mom, maybe dad. Okay. So skin to skin, thermal regulation is important. Depending on their age and size, sometimes they're on a warmer to maintain their body temperature if they can't maintain their own body temperature in an open crib. We need to be protecting them from infection for sure, keeping them hydrated. So a lot of the things we're thinking about for them is respiratory, warmth, feeding, and then we still have to promote bonding. Okay, a lot of times the parents are really afraid to touch their babies or to interact with their babies. So promoting bonding, explaining what the equipment is and what it's doing, giving them decisions where they can make decisions are all important for this. All right, and that is the end of high risk newborn. Hope you have a great day.